Okay, so good afternoon, everyone. We're ready to get started. Today, we are hosting Dr. Frank Buttacavoli, and he's going to be talking about knee pain and evaluation and treatment of knee arthritis to help you all get moving again. Dr. Frank Buttacavoli completed his degree in economics at Rice University, and he attended the University of Miami for medical school and matched for the orthopedic residency at UT Health San Antonio. After residency, he completed his fellowship training in adult hip and knee reconstruction at Brigham and Women's Hospital, Harvard Medical School. Dr. Buttacavoli's specific interests include hip and knee replacements, as well as revisions of failed replacements. He has clinical interest in improving long-term patient outcomes within these procedures and cost containment for future healthcare models without sacrificing patient satisfaction and outcomes. He has previous experience with patient-specific implants, robotics, revision surgery, and the use of stem cells and biologics in treatment of hip and knee disorders. So welcome, Dr. Buttacavoli.
Okay, thanks for that introduction. Can everybody hear me? Good. Okay, perfect. Thanks for having me today. We're going to talk about knee arthritis and kind of the beginnings of knee arthritis and the end stage treatment for knee arthritis in our Get Moving Again series. A lot of the things I'll cover for knee arthritis today, they're applicable to hip arthritis as well. And I've seen a lot of the pre-questions, so we'll discuss a little bit of both those as well. And again, thank you for having me. This first slide's a picture at my graduation from UT Health here in San Antonio, and I don't really give a presentation without talking about the mentors that taught me. And in the middle there, the two older guys around the younger guys, one of them is named Charles Rockwood, who's the father of our program and the father of shoulder surgery in the United States. And the man above him is Jimmy Andrews, who you probably see on the sidelines at a lot of NFL games, as he's the most used person for sports medicine type injuries around the country for the professional athletes. This is a picture at my fellowship with my fellowship director, Dan Estock at Harvard Medical School. And here's where I really honed in on my surgical skills with specific hip and knee surgeries. And I appreciate everything he taught me, and I don't give a talk without mentioning him. So what to know about arthritis? There's a lot to know, and there's lots of different types of arthritis, and we'll jump into that right away. So, just looking at the word, it's basically joint inflammation when you break down the word. And there are lots of ways inflammation can happen. Most of the time, it's your body's normal response to injury. Sometimes there's patients with diseases where, like rheumatoid arthritis or lupus, where their body inappropriately attacks the joint, and we'll discuss that with some pictures shortly. Arthritis is very common. I pray for the day that stem cells and some other things work better, but right now it looks like I'm going to have a job for a very long time, because arthritis affects almost everybody once you reach a certain age. I think the most common reason for arthritis is just normal wear and tear that comes with living our lives. It's the leading cause of disability in the United States. And the Center for Disease Control projects that the number of Americans over 65 who will suffer from arthritis will double by 2030. And when we look at the projections for knee replacement, we think knee replacements will be done 10 to 20 times more than they are today. There's many different types of arthritis. And like I mentioned before, the most common type is normal wear and tear osteoarthritis. And that comes from what you demand of your joint throughout a period of your lifespan. And most commonly, somebody comes into my office around the age of 55 or 60 with some of that early wear and tear, and it can increase to the point where we talk about joint replacement. Other types of arthritis that may affect some of you in the crowd listening today, so definitely worth mentioning. Infections can cause arthritis because infections eat away your cartilage, and if you have an infection that seeds your knee or your hip, it can lead to arthritis, and that can be a more complex treatment. Rheumatoid arthritis is probably one of the more common arthritis. It used to be the #1 reason we did joint replacement in the 80s. But the rheumatoid medicines have gotten so much better over the last 25 years that the majority of the people I treat with knee replacement have run-of-the-mill osteoarthritis. But when we started doing joint replacement, the most common patient we saw was somebody with rheumatoid arthritis. The medicines in that arena have really been a big change in healthcare over the last 30 years. Psoriatic arthritis, psoriasis, isn't just a disease of the skin, it's a disease of the musculoskeletal system as well. And it can affect your joints and give you a specific type of arthritic pattern. Post-traumatic arthritis is kind of a global term for, let's say you had a normal knee and you got in a car accident, you had a fracture that involved the joint surface of the knee. The biggest risk of that injury is developing arthritis in that joint after. And those patients can be a little bit different to treat because I might have to deal with plates and screws or nails from their previous fracture fixation when I'm trying to do a knee replacement. Osteonecrosis can come from multiple things: sickle cell disease, excessive alcohol use, or sometimes medications you might be taking. Sometimes we see younger patients who take medications for leukemia or lymphoma, and it can lead to osteonecrosis of their bone. What's osteonecrosis of the bone? It's basically where the blood supply to the bone no longer supplies that area of bone and cartilage, and it essentially dies. There's also some congenital deformities. There's a wide range of them, but sometimes you get arthritis because of how your bones were built in mom's uterus. And there's also some genetic inherited diseases that can give you different diseases within your joints. How and why does arthritis happen? Sorry about that. We don't fully understand the answer for run-of-the-mill arthritis. There is a genetic component involved, although it's poorly understood. I think genetics do play a role. The thing that we do know most commonly is there's a large association between arthritis and obesity. So I think the number one thing you can do as a preventative measure is making sure that your weight and your overall general medical health don't get to a point where they're making your arthritis or the burden on your joints worse. So this is a picture of the knee joint. This is a normal x-ray where I'm looking from the front, and you'll see there's some bony anatomic landmarks that are marked. It's one of the largest joints in the body, and it takes quite a load when you walk. When you're in single leg stance on your leg, about 4 times your body weight is going through your knee. The knee has some linkages between some ligaments: the anterior cruciate ligament, the posterior cruciate ligament, and the collateral ligaments, or the ligaments on the side. And that leads to a mechanism where your knee slides and rolls throughout an arc of motion. This picture is a little bit different. This is an intraoperative picture of an arthroscopic surgery. And that looks like a perfect knee joint. And it's only one side of the knee joint that's pictured, but you can see in the center, there's this structure here, and that's the meniscus. And the meniscus is not cartilage. It's a cartilage-like structure, but it's actually the padding or the cushion between your 2 cartilage structures on the femur and the tibia, which make up your knee joint. Normal cartilage is made of hyaline cartilage, and unfortunately, we haven't found a way to grow back hyaline cartilage, and that's been the biggest problem with treating people with early cartilage loss, because we haven't figured out a way to stop it. There's a lot of research in this area because it would improve patient outcomes and improve. As much as I like doing knee replacements and hip replacements, if we didn't have to do them, I think that'd be a great thing if we could stay with the parts that we were born with. But unfortunately, they do wear out. And once you have a cartilage injury, it's tough for it to stop getting worse. The meniscus I talked about a little earlier, because that slide that showed it in the arthroscopic picture, but it's that cushion in between. And sometimes you have no issues with your cartilage, but your meniscus or your shock absorber can tear. And sometimes that can be treated with an arthroscopic surgery. The meniscus also gets a lot of wear and tear as you go throughout your life. And if you got an MRI of everybody over the age of 60 years old, it's going to show a meniscal tear. So what do you do with that meniscal tear when you see it? Really, it depends on the morphology or the type of meniscus tear you have and the symptoms that it's causing. Sometimes going after a meniscus arthroscopically can actually accelerate your arthritis if you're not careful. So when you see your MRI report that says there's some fraying in your meniscus, a lot of time that's a normal age-related variant. When you start to get arthritis, that pearly white cartilage that you saw in the previous arthroscopic image is gone. And you go down to the level of what's called the subchondral bone, or the area below the cartilage. And there's a lot of nerve fibers there, and that's why it hurts. And when you put your weight on your leg, it hurts to move and it hurts to climb stairs. And you also lose that smooth, even surface, so that when you do go through an arc of motion, you feel clicking and catching and pain. Who's at risk for arthritis? We talked about people who have previous trauma. There's definitely some occupational factors. If you do a lot of repetitive tasks where you're doing heavy lifting or overworking the joint or putting too much force through that joint, it can definitely increase the risk of needing a knee replacement in the future. And we talked a little bit about genetics. There's certain mutations that are correlated with osteoarthritis, but again, it's poorly understood with regards to genetics. Lastly, I want to touch on obesity. Generally, the more weight a person carries, that's going to be more pressure on the weight-bearing joints of your body. And the weight-bearing joints of your body are the joints in your feet, the joints in your ankle, your knee joint, and your hip joint. And those are the ones that take on the most load as you're walking and trying to get along through your day. So if you look at some statistics on arthritis in the US, it's more common in females, and it's definitely a little bit more common in inactive patients. So just because you have arthritis doesn't mean you should stop being active. You need to try to do the most you can, even with your arthritic joint. If not, the soft tissue and the muscles around the knee might get weaker, and it might lead to a progression of your arthritis if the normal stabilizing forces of your knee aren't functioning well. And when you look at age, we talked about the different types of arthritis. And when you look at that 18 to 44 group, that's the arthritis that's more likely going to be caused by trauma or medical illness that also affects your joints, or sometimes medication reactions that lead to cartilage issues in the knee or hip. But the most common patient I see is a 65-year-old person with osteoarthritis of their knee from normal wear and tear throughout their lifetime. We talked about weight, and when we look at weight, we look at body mass index, which is a calculation based on your height and weight. It's not perfect. We're not all shaped the same. Some of us are oval, some of us are pear, but it is something we look at because we do have a lot of data that shows if we do a knee replacement, your risk for infection goes quite a bit higher once you're over a BMI of 40. Some signs and symptoms of arthritis. The most common symptom is pain, but you might notice stiffness, and stiffness occurs because your body responds to the arthritic change in your knee by creating more joint fluid. So you might notice that you can feel a fluid shift within your knee, or you can feel that your knee is just overall swollen. When a patient that comes to me that says, on mile 4 of my run, it really hurts, that's probably not somebody that we're going to talk about a joint replacement. But if you came to my office and said, every time I try to walk through the grocery store, I have to lean on the cart and I can't get through without it, you probably have a level of arthritis that's probably reasonable to discuss joint replacement. So the joint deformities that occur, you can be knock-kneed or bow-legged, and the terms are varus and valgus. Really just depends on which part of your knee or which compartment of your knee is failing. And over time, it starts to affect all the compartments because your normal mechanics in the knee are disrupted. And here's a picture of, what the normal alignment looks like and the alignment with arthritic change. Some people are born with knock knees or bow leg, and then yes, they have a predisposition to getting arthritis because of their malalignment from birth. Lots of ways to treat arthritis, and surgery isn't the only answer. The biggest preventative thing that you can do is don't let weight become a problem, because once you have arthritis, if weight's already a problem, it's very difficult to lose weight when you have joints that aren't letting you do what you want to do. So if you're listening to the talk today and arthritis really isn't a problem for you, but weight's a problem, the biggest thing you need to take from this talk is to get your weight and your general medical health under control, so that if you do get arthritis in the future, you'll be able to tackle it much better. There's no cure per se for arthritis, and we really hope in my lifetime that we have some sort of biologic or additive way to regrow cartilage, but that's the main problem. We can't regrow cartilage. Once cartilage is gone, um, we have a certain type of procedures that we try for cartilage restoration. Some of them work much better in younger patients, but in older patients, we haven't been too successful with that. When we talk about treatment of knee arthritis, I break it up into surgical and non-surgical treatment. Some of the non-surgical treatment, we talked about some of the health and behavior modifications, and whether you have arthritis or not, I think this is an important part of your daily routine, a daily exercise program, balanced diet. That doesn't mean don't live your life, but it doesn't mean live your life excessively every day. There's a fine balance in there that you'll have to find. Um, we all hope for a pill that can take care of our symptoms. Tylenol and Aleve are probably the mainstay of treatment for arthritic pain. If you're requiring more than that, it's probably time to talk about joint replacement. We're really struggling with a narcotic battle in this country, and we don't want to put you on narcotic pain medicine for your knee pain, not because we're trying to be mean about it, but we know what happens. And if you get dependent on these narcotics, your pain never really goes away, and you get some side effects from the narcotics that are really irreversible. It can be a lot of liver damage and kidney damage to some of the medications we prescribe, and narcotics are really meant for short term after a surgical procedure. Some of the other things we have are intra-articular injections. None of these change your x-ray. They look to change your symptoms. And if you can get along with some sort of non-operative treatment for an extended period of time, I think it's worth delaying joint replacement. The most common thing you'll find is a steroid injection. The negatives to steroid are that it tends to work less the next time you do it. Always when I do it, my hope is that a patient gets 6 months to a year of relief. If they don't, I worry that steroid injection is probably not a good option for that patient anymore. And it's more reasonable to talk about another form of non-operative treatment or discuss knee replacement at that time, depending on what their x-rays look like and how much they're suffering from their knee pain. Viscosupplementation is kind of this encompassing term for what a lot of you have probably heard as the rooster injections. There is a company that uses the comb of the rooster, and that's where it comes from. But basically, it's hyaluronic acid, and that's a normal part of our synovial joint fluid. And there are some injections out there called viscosupplementation or hyaluronic acid. Some of them come in series of 3, some of them come in series of 5. That the hope is to put this gel-like substance into your knee to create environment more like the normal knee for better gliding and improved motion with less pain. The data is mixed out there. There's a lot of insurance companies that give a lot of pushback on this because the data is not very good for it. Overall, it hasn't been shown to be terribly beneficial. In my experience, I don't mind trying it once with a patient. If it gives you a year relief, I would do it again. If you got it and it didn't help you at all, I really wouldn't recommend doing it because there are negatives to every time you put a needle in the joint and any time you put something foreign in your body. So if it's not giving you benefit, I wouldn't do it. Biologics is the biggest thing that people are talking about now. We see the athletes getting PRP shots and stem cell injections with the hope that they can continue to play for their large salaries. And it's hard to extrapolate the professional athlete N of ones and N of twos to the overall population. I think the business side of biologics has probably outrun the research side. We don't have a lot of great research that shows we're doing that what we hope PRP and stem cells would be doing. PRP is platelet-rich plasma, and we'll talk about some of those options now. NSAIDs we talked about a little. This is the first line of therapy. There's a lot of different types of NSAIDs, and they can be a little bit tough on your kidneys. So if you're taking Aleve, ibuprofen, and Motrin, all those things are the same. And you're tripling up on a similar medicine, and that can really lead to reflux issues, ulcers. So you really want to make sure you're not doubling up and tripling up on the same class of medicines. But that is the first line of treatment for arthritis. And I think the Aleves, the Motrins, and the prescription ones are called Meloxicam and Celebrex. They're all similar medications, and they can help with your symptoms. But if you do take them long term, we probably want to check your kidney function every so often and make sure that you're not developing an ulcer or any issues with your esophageal lining. The injections we talked about a little bit before, and they're injected directly into the joint. When you have an injection done by a physician, you want to make sure that the skin's clean. I use a combination of alcohol and iodine when I'm putting the injection in. I think it's important because once or twice a year, a patient gets sent to me that got an injection, and because of that injection, they got an infection. So you can bring bacteria from your skin and the outside world into the knee joint. So you want to make sure that if you are getting an injection from your provider, that the knee is sterilely prepped prior. Visco supplementation, we talked about this, and we'll go into it a little bit more because it's being criticized by the American Academy of Orthopedic Surgeons, because when we look at our research, it's not great. Again, I don't mind doing it with a patient that's trying to avoid knee replacement, but insurance companies are giving more pushback on this option. PRP and stem cells is the newest thing over the last 5 years. I hope there's a future for it. I haven't seen it in knee arthritis. There is some data that PRP injections, which is your own platelets taken from your blood and concentrated and then put back into the knee, with the hope that certain growth factors help make a better environment in your mildly arthritic knee. There's a little bit of data that shows it can help in some of the patients with mild arthritis, but I think once you have a level of arthritis that's bone on bone with no cartilage remaining, we haven't seen any data to show that PRP or stem cell injections is helping in that population. We have studies ongoing at our institution. We definitely hope there's a future for this, because I think this is a lot easier for a patient than getting a knee replacement. But unfortunately, the knee replacements is the gold standard right now for end stage bone on bone arthritis for a patient that's having trouble doing simple activities of daily living. When we look at evidence-based treatment of arthritis, there's a lot of stuff that's all over the place. And people, and I'll hone in on one here mainly for this slide, is physical therapy. I think it's important for you to do as much as you can with your perfectly normal knee or your arthritic knee. You need to be doing something every day, not so much for your knee, but for your heart, lungs, and kidneys and the other organs in your body, because we do know that if you become sedentary, the lasting effects on your other joints and your other organs is really the problem with it, which is why we want you moving. We want you outside doing things. And, we look at our kids now who are having more and more of a problem with not going out to play as much and not going out to do things outside because they're living on computers and iPads more often. And there's definitely some positives to computers and iPads, but one of the negatives we're seeing is the rise in obesity in our younger population. And we worry about what we're going to see arthritis wise and really end organ damage wise to these changes in lifestyle that we're seeing. So surgical treatment for knee arthritis is not a scope. Some people ask me if I can take care of their arthritis with the 2 little small incisions and go in with the scope and the camera and clean it out. Most of the time that makes you worse. If you really have isolated meniscus pathology, then a scope is a good procedure for you. But if you have bone on bone arthritis with no cartilage remaining, arthroplasty or total joint replacement is the treatment of choice. Arthroplasty or total joint replacement, here's some just bullet points to discuss. It's a surgical procedure for a diseased or damaged joint, and you're placing artificial components, and we've gotten a lot better with those artificial components. The components are made of fancy metals and fancy plastics. And if you have an allergy to nickel or certain types of metals, there are different implant options for those patients with allergies. We really started joint replacement in the 70s, and I'll show a picture of a gentleman who was really the father of hip replacement, who left us some lasting knowledge and messages with his revolutionary work. Roughly 1 million individuals had hip or knee replacement surgery in 2010, and that's expected to be 3 million by 2030. So the numbers are going up. There's lots and lots of success stories. There's some people who don't have perfect outcomes, and we'll talk about that a little as well. So this is what a knee replacement looks like. And, the goal of knee replacement is to replace your arthritic surface with these metal and plastic components and restore your alignment and give you a stable knee throughout an arc of motion. It's not meant for you to return to running a marathon. It's meant for the person that was having trouble doing simple things. And now with your new knee, my hope is that you can walk from Texas to California if you wanted to. Walking is really what we do this for you to walk without pain. If you come into my office and say, when I'm on the track running and jumping hurdles, knee replacement's not probably something we're going to talk about for you. So when we do a knee replacement, the amount of bone I shave off can probably fit into a teacup. It's not like I'm chopping a ton of bone off, and you can see it's almost a shaving of the bone to accept the implants. And these are some diagram type pictures if you can see where we take the bone off the femur and where we take the bone off the tibia. And the bone we're taking away is the diseased cartilage, and we replace that surface with the implant. The implants can be press fit on with or without cement. For me, in my practice, that depends on the quality of your bone. If you have very osteoporotic bone, press fitting an implant onto your bone without any cement probably has a higher risk of fracture in my practice. So I'll tend to cement that patient. Or somebody with younger, better bone that just has run-of-the-mill arthritis from wear and tear, I might not use cement on that patient. So when you look at the diagrams here, here's what a normal knee x-ray looks like. And really, in these cases, a picture does tell 1,000 words. That's an arthritic knee, and that's a severely arthritic knee where they're almost digging a cup into the inside of their knee there. And that's quite a bit of bone loss involved. And that's after the surgery is done with the replaced knee. A shorter incision doesn't necessarily mean a better surgery or shorter rehab. It's how you treat the muscles and the tissue underneath. My practice, a lot of what I do is revise replacements gone bad. And a lot of times, I think sometimes they weren't done well because the initial surgeon couldn't see what they were doing. And one of my favorite quotes from my mentor is that he had a horrible habit of liking to see what he was doing. And ultimately, how I put the components in your knee and how I balance the tissues when doing the procedure is what's going to give you a long-lasting result, not the size of your incision. So the major goals for knee replacement are to relieve pain and restore proper joint motion. If you come in very stiff, I think I can get you more motion with your knee replacement, but the main reason to have a knee replacement done is for pain, and hopefully you get a little more motion as well. Patients can return to most of their normal activities following total knee replacement. I have some patients that run on their total knee replacement, but I don't advise it just because these parts can wear out too. And if you're putting excessive amounts of activity like running or jumping type sports, you might have to get a revision of your knee replacement in the early 10 to 15 year range instead of the 25 to 30 year range. I think if you're walking with your knee and doing normal activities of daily living and you're 65 years old, I can reliably say that when I do your knee replacement, the knee replacement should outlive you at that point. Unfortunately, these fail, and a lot of the times it's because either what's being demanded of it or some of the older implants we use, which have gotten significantly better. And we do a lot of procedures to revise these ones gone bad. I have a long conversation with my younger, more active patients who have joint replacement. They need close follow-up, and they should get an x-ray every year or two, because sometimes I see something simple where I can go in and just change a plastic liner instead of having to start all over again and taking all the components out. I wanted to talk about the at-risk patient because I don't want you to think your doctor's trying to be mean when they're telling you to lose weight or do certain things. It's just, we know what happens. And unfortunately, unfortunately, bad things do happen sometimes. And if you want your joint replacements to be successful, there's a lot of work that needs to be done before surgery to tee you up for a good result. And I worry about people with previous incisions from trauma. If you have incisions that are too close together, it can lead to skin healing issues. If you have vascular issues, whether it's due to your veins and arteries just have disease or because you smoke, those people have higher risk during surgery. If your diabetes isn't under good control, we know that your risk of infection is significantly higher. We look at hemoglobin A1Cs, and I shoot for somebody around 7.0 or less. The lower, the better. BMI, we've talked about. We're not trying to be mean when we say this to you. And, we say it to ourselves, and we say it to our own families too, because the data is very convincing. And for the health of your knee, the quality of your knee replacement after surgery, and the quality of your overall general medical health, BMI is very important. We talked about smoking and drug use, and some of these things put you at increased risk for infection. And then some people come with a bag of goods because of the diseases that they bring to the table, and we'll have to do some special things for those patients to try and optimize them for surgery. If you do have injections before surgery, it's recommended that you wait at least 3 to 4 months after your injection before having knee replacement, because when you do have steroid in that area, it does put you at a little bit of increased risk for infection. We also look at your oral hygiene to make sure that nothing can be done to correct any hygiene issues in your mouth before having joint replacement. Here's some real life examples. When somebody gets an infection, we have to take that joint out and we put a cement block in the knee, and the cement has antibiotics in it, and it eludes antibiotics into the tissue. And once we clear that infection and optimize your medical health, we can go back and put a new knee in, and that's what this would look like. And obviously that doesn't look like a normal knee replacement. It requires a little bit more metal and plastic to reconstruct the missing bone that occurs from taking out a previous implant. So I wanted to review some questions at this time. We've received some before, and is having stiffness a part of arthritis? And it's absolutely a part of arthritis. Your knee responds to your arthritic change by making more bone, and your knee gets bulkier and you get more fluid in your knee, and stiffness is a part of that. It can also affect stiffness in your feet and ankles, because sometimes people get swelling that goes not only into the knees, but into their lower extremities down towards their feet, and that can cause some stiffness as well. Some people ask if they have crooked legs, is there other things besides surgery that can help? You may remember a lot of your friends with certain bracing options when they were children. We don't really do that much anymore because we find that it doesn't really help. I think if you develop a level of arthritis that we need to talk about joint replacement, we can address your alignment at the time of joint replacement. What's the best exercise to not cause injury for someone in their mid-50s? I think walking is probably the best exercise to not cause injury. It doesn't mean you can't hurt yourself walking if you're not paying attention and you step in a hole. It's the common story I see, or they trip on a curb. But walking is probably the best exercise. The goal is to walk at a pace that gets your target heart rate to where you're working. And it's an exercise. If you walk at a very slow pace, there's not a significant health benefit to that. So you need to walk at a pace where your heart is working as well. People asked about non-surgical procedures. I think we've discussed those. Why do I have continued pain when I kneel? So before surgery, kneeling on your bony prominences can cause pain because we don't have a lot of cushion around the knee. It's a thin skin envelope. And then when you have an incision over the front of the knee, sometimes kneeling on that incision can be painful. I have some patients who pray every day because of their religion, and I recommend that they wear a knee pad when they do that if it's uncomfortable. What's the best non-surgical procedure for an arthritic knee? I think the data would show that weight loss and non-steroidal anti-inflammatories are the best options. But all the things we discussed are options, and I think it's reasonable to use all those options before jumping to a knee replacement. Are there any alternative folk medicine treatments that work for knee pain? There's a lot of anecdotal data that cooking with turmeric has some anti-inflammatory properties and can help with the inflammatory component of knee replacement. But overall, a lot of the other types of treatments like dry needling and acupuncture aren't really well studied, so we don't have great data. So I couldn't tell you with confidence that those things help. What's the best way to get moving safely for obese patients who want to be healthier without doing more damage to our joints? It's a great question. And I think I want to go backwards with that question and talk about, I want you to get a hold of your weight and your general medical health before you get arthritic knees and hips. If you're past that already, getting into a pool can be a lot easier on your joints if you're trying to do some form of exercise to lose weight. The other thing that can help, you can get yourself a cool walking stick or even a walker. If you told me I'm going to walk for an hour with a walker, or I'm going to walk for 10 minutes without the walker, I want you to walk for an hour with the walker. And that's going to help you lose weight and tackle your obesity issues. When are stem cells appropriate for problem knees? I think anybody that tells you they know the answer to this is lying. And I think there's a big financial incentive for stem cells, and people are selling a lot of it. I want it to work. I do, but there's no data that shows that yet. And I don't want my patients, I see a lot of patients that have spent upwards of $5,000 to $10,000 on a lot of these injections with no help. So I do worry about the financial burden to my patients if they're going and getting that elsewhere. We're studying it here at the university. We're hoping for some success with it, but we haven't seen it quite yet. Okay, any other new questions from the docket?
Yes, so we have a question in the chat. Great question. Can you comment on the recovery process for the patient and or spouse or care provider? How much time should I need to take off to care for the spouse?
Great question. I think joint replacement's a big team effort. We have a huge team. We have a preoperative joint class that people go to before surgery, and a lot of these questions are answered. Everybody's different, but I think if you can have somebody at home for the first 2 weeks, it's a big help. Not everybody needs it, but having somebody at home for 2 weeks is reasonable. And I think your loved one or your friend, if you're around helping them after knee replacement, whether it's with just simple things like preparing food and simple household chores, that can be really helpful to the patient. Recovering from your total knee really can take about a year, but I'd say 90% of the recovery happens in the first 6 weeks. The first 2 weeks are tough, and you're probably cursing your surgeon's name a lot of the time. But at the 2-week mark, you kind of turn the corner, and at the 6-week mark, you really turn the corner. And for people with really bad arthritis, they're really glad they had it done by about the 6-week mark.
If allergic to nickel, would a total plastic replacement be used?
There is no such thing as a total plastic replacement. There is a total plastic tibial component, but we don't have a total plastic femoral component, but we do have nickel-free implants. They're actually not fully nickel-free, but the nickel in them is a really trace amount, and they've been shown to be helpful with patients with nickel allergy.
If you live alone without a family care provider, can you make it through those early weeks alone?
It's a great question, and the answer is yes, you can, but I think getting support from friends or other people in your neighborhood or that you see often would definitely be beneficial. Sometimes if you don't progress to a certain point with a therapist in the hospital after your knee replacement, we do send you to a rehab, but we really try to avoid that because the data shows if you're at a rehab, your infection risk is going to be higher. And that really makes sense because you're not just there with a bunch of knee replacement patients, you're there with other sick people. So the goal is to go home. I'd say about 20% of my patients go home the same day, 70% go home the next day. And then that last 10% might be that patient that stays 2 days, or we consider for rehabilitation stay, but we try to avoid it.
So Sylvia has a question. Can you find physical therapy exercises online or YouTube versus going to physical therapy appointments?
Absolutely. I think the American Academy of Orthopaedic Surgery website has a lot of information on knee strengthening and exercises that you can use at home. There are a lot of, the Mayo Clinic's website has a lot of that as well. And those are the most 2 common websites I recommend to my patients.
Robin asks, is tennis okay after a knee replacement?
A lot of times I'll tell my patients, if you want your knee to last 25 to 30 years, I recommend doubles tennis. But a lot of times with things like tennis and skiing and golf, if you've done it before and you're quite good at it, I'd never want to take that away from your life. So tennis isn't one of the things where I tell people they can't do it. But I think if you can play doubles tennis, that might lead to less wear on your implant, especially if you're a patient that's in their early 50s that got joint replacement, where we really want to monitor your activity a little bit more.
Lynette wants to know, she's a runner and cannot get her heart rate up any other way. Do you have any other ideas? Running has been her best exercise for many years, but now her knee pain limits this activity.
I think at that point, you can avoid the pounding of running, but you can still get on a elliptical machine or an exercise bike where you avoid the pounding, but can still get up to the speed and resistance to where your heart gets moving.
Laura asks, when doing a hip replacement, do you cut from the front or in the back?
That's a great question. I think a lot of my practice has grown because I do hip replacements through the front. But at the same time, if you have a lot of belly that's overhanging, we all know what grows in that groin crease. So if you have that, I do try to avoid hip replacement through the front. I have some patients that really want their hip replacement through the front because we do have data that shows earlier recovery occurs with those patients. It's a procedure where I go between two muscles instead of cut muscle. So I have a lot of patients that I'm super proud of because they want their hip done through the front, they lose some weight, their belly gets smaller, and we go through the front. Getting your hip replacement done through the side or the back, it's the best procedure in medicine. If you have bad hip arthritis, you're going to love it too. So if you love your surgeon that does their hip replacement through the front or the back, as long as the parts are put in a good spot and the tissues are treated well during the surgery, you should have a great outcome.
One of our attendees asks, do you recommend using orthopedic shoe inserts?
Depending on how your knees are and how the alignment of your legs are, sometimes we can put inserts in your shoe to help offload your knee joint, and that is a reasonable non-operative thing to try. All of you that tuned in today, we had a raffle, and the giveaway winner is, last name right, Barbara Toller. Congratulations. Thanks for tuning in. And I hope everybody's questions were answered. And I hope you found the information valuable. And I hope you all have a great holiday season.